for your kingdom in this time of pandemic. Do not allow us to be indifferent to those who today suffer the loss of a loved one or who suffer from the absence of work, but give us the courage to accompany and side with those who suffer violence or injustice. Amen.
Amen. And with that, ladies and gentlemen, if you have something to drink, I'll just ask you to kindly raise your glass. Alternatively, we can have the hand to the chest as we raise a toast to the President of the Republic of Kenya. To the President.
Nice to see Elizabeth and Anne.
Ah, yes. Well,
thank you. She's going to be our moderator for tomorrow's program, so we are meeting to discuss that.
Wonderful. Which brings
but we're also meeting to discuss friendship.
Wonderful. Which brings us to the announcements before we carry forward. And the first announcement actually is past President Anne, family of Rotary. Sorry, you're on mute.
Mr. President.
Yes.
Fellow Rotarians. We are planning to celebrate Mother's Day tomorrow. We'll be celebrating motherhood. Everyone, both Rotarians and non-Rotarians, to join us. And the fathers also to join us tomorrow. And we're expecting 1 or 2 special guests. I hope they show up. And I know that every day should be a Mother's Day. So, and it's also good to hear from one another, your experience as a mother, from yourself, and what's that childhood memory that you have of your mom. So,
yes.
Yeah, we're going to share it just now.
Okay.
Yeah.
We're definitely.
And Dr. Manu, also, you have to share your childhood experience with us. And PP Arun has also agreed to do that. So you are not in school. And how many brothers are you? And all that. We would like to hear that.
Okay.
Thank you.
Thank you. Thank you so much. We look forward to that wonderful meeting, which is organized for 5:30 p.m. East Africa time tomorrow. And the next announcement is by our Youth Service Director, Rotarian Winnie.
Thank you, President Ritesh, fellow Rotarians and friends. It's a great honor. The month of May is a Rotary Youth Month. And next week on the 20th, RCN in collaboration with Interact Clubs and the Rotary Clubs, we shall be celebrating by showcasing our activities. And as well, we shall be also having highlights on mentorship programs. We shall have very great speakers, that is Dr. Sally and Dr. David Gedanga. So welcome and also invite your friends. So thank you very much, and we look forward to seeing you next week. Posters will be shared in the course of the week. Thank you very much, President Ritesh.
Thank you so much, Rotarian Winnie, and we look forward to that wonderful meeting, which will take place next Thursday as well.
Thank you.
And since we are running against time and we have to be on schedule, I will quickly request individuals to kindly let us know who their visiting guests are. And first, I'd like to acknowledge the presence of our wonderful speaker today. Rotarian Rashmi will be introducing our wonderful speaker today, Dr. Veena Kalra. And Rotarian Rashmi, would you like to introduce your other guests today?
Thank you, President Ritesh. I have a few guests, but I can't see all of them, but I think there is, we are joined by Dr. Veena Kalra and her 2 sons, Mr. Vikram Kalra and Mr. Vivek Kalra. And we have Monica from Kenya who has joined in. And I think there are a few more. I'm talking on 2 devices, so I cannot access the images. So if you excuse me, I think they'll speak up when there are questions, etc. Would you like me to introduce Dr. Kalra now, or?
Once we have actually acknowledged the presence of all the Rotarians and guests,
Okay.
definitely. Thank you and welcome. Welcome to all your guests. We have with us past President Leah from Rotary Club of Bahari. Welcome. We have with us Rotarian Perry all the way from America. Welcome. And we have Ambassador Dr. Josephine. Would you like to say a quick hello to past President Juvenal?
Yes, thank you very much, President Ritesh, fellow Rotarians and guests. I'm honored to introduce a long-term friend. His name is Juvenal Shihundu. Juvenal is a colleague whom I work very closely with in the multilateral settings where I worked both in New York and also in London. Juvenal has been a very senior leader, PT director, and head of program management for 11 years at the International Maritime Organization, which is headquartered in London. He has also, in that capacity, acquired a trusteeship called the Apostleship of the Sea. He's held this position for 1 year. He's now currently, I think, General Manager of African Marine and General Engineering Company Limited, and also has a nomination to chair, I think, the Kenya Maritime Organization, a board of the Kenya Maritime Organization. Beyond that, Juvenal is the vice president of the Kenyan Society in London. And I'm delighted to say I handed over the president's position at the Rotary Club of Westminster West to Juvenal Shihundu. Juvenal is also serving right now on a program that our club is hosting called COVID-19 Education. I just want him to feel most welcome to join us this afternoon. Juvenal is now in Nairobi for a short spell, but is actually based in London with his family. Welcome, Juvenal.
Thank you, Josephine.
Thank you. Thank you so much. And we are very grateful for your presence. Welcome to all the Rotarians and guests. And now I'd like to play a short video, which is by Radio 44, our media partners for today. This is just to give a glimpse to all the individuals who have logged on and who will watch this YouTube video of the advertising which has been taking place for our meeting today. So I'll play the short clip, and thereafter I'll call upon Hermina.
As well. Let's talk about the Rotary Club of Nairobi, the flagship Rotary Club of Africa, and they're celebrating their 90th year in operation. Now, it's very rare to come across a club that absolutely and undoubtedly takes care of people, humanity at its pinnacle. Philanthropy is the key principle of the Rotary Club of Nairobi. And tomorrow between 1 and 2 p.m. via Zoom, the Rotary Club in partnership with Radio 44 presents a talk by Professor Dr. Veena Kalra. Now, she was actually formerly a professor and the head of pediatrics at the All India Institute of Medical Sciences, that's AIMS, that everyone knows. And she's actually been awarded multiple recognitions by several presidents of India over her illustrious medical career. Now, this is something that you cannot miss because, trust me, it's all about the COVID-19 pandemic. And we see a lot of information all over the media, you know, on Facebook and social media sites and everything. But sometimes that information is not actually accurate. So this is the best way for you to actually get the right information. So that's what it is. Tomorrow between 1 and 2 p.m. via Zoom meeting. Ensure that you keep yourself busy and join us, all right, the Rotary Club and Radio 44 as we educate you. And this is something that's absolutely going to benefit you. So make sure you save the date.
Thank you so much. And with that, I will now call upon Hermina, who's the station manager of Radio 44 Kenya. Hermina, welcome.
Hi, thank you so much. I mean, for you to even share that with everyone to see what Radio 44 does. Like I said before, it's our pleasure to partner with you and help in giving the great work that Rotary is doing some exposure in Nairobi and also around the world.
Thank you. Thank you so much, Hermina. And please do say a quick hello to our wonderful speaker for today. And thereafter, I'll call on Rotarian Rashmi to introduce the speaker.
Well, I just want to say thank you for the great work you're doing with COVID-19, as well as involving the world and letting them know what you're doing. So keep up the good work, and we're at Radio 44 are, again, it's a pleasure for us to support what you're doing and play our small part.
Thank you so much, Hermina. Thank you. And Lokiri and Rashmi, can you kindly do us the honor of introducing our wonderful speaker for today?
Good afternoon. Good afternoon, Rotarians. It is my great pleasure today to welcome Professor Dr. Veena Kalra to our club fellowship. Professor Dr. Veena Kalra is the director of the Child Center Pediatrics Neurology Institute of Neurosciences in Delhi, India. And she is a former professor and head of pediatrics at the All India Institute of Medical Sciences. She's had a very remarkable academic and professional career, which began with her topping MBBS from Delhi University and MD Pediatrics from the AIIMS. She's the recipient of numerous awards and recognitions for academics over a career which has spanned 45 years and has received several prestigious awards, the chief amongst them being honored by not one, but three presidents of India, where she got an award for excellence in academic studies from Honorable Dr. V.V. Giri. Then from Shri Gyani Zail Singh, she got the Kanishk Shiromani Award for Medical Education. From Honorable Dr. APJ Abdul Kalam, she received the Best Alumni Award for Maulana Azad Medical College for her outstanding contribution to pediatrics and child neurology. She is a recipient of 31 medals and awards, including President of India medals, the Sorel Catherine Research Award, Pfizer Gold Medal, and the Asian Research Award. She was the person who actually established a postdoctoral course in a super specialty area of DM pediatric neurology at AIIMS, and has delivered several orations on prevention of childhood neurodisability at various conferences, and has bibliographed Medgate Day, a coffee table on India's top pediatricians. Recently, this is last year when she's done this. She's delivered the OP Ghai oration on pediatric neurology. She's conferred the Business Excellence and Innovative Best Practices at 2019. She was chosen as the Joint Minister. She's been bestowed the Swasth Bharatiya Saman by ZTV and LIC for contribution to pediatrics. She has been engaged in the promotion of child neurology both nationally and internationally, and has chaired several scientific sessions. She's the founder president of Association of Child Neurology India. She's the former president of Asian Oceanian Child Neurology Association in Japan, and she is the chairperson of Education Committee of International Child Neurology Association. She has had more than 60 research papers in child neurology and liver disease of children, genetics and inborn errors of metabolism, and has published more than 230 original research papers in many national and international journals. She has contributed more than 50 chapters on pediatrics and child neurology, and has authored a book, Practical Pediatric Neurology, which is the textbook for which nearly 3 editions have been published. I can actually go on. There is much more to talk about her excellent professional qualifications. But I would like to say that I've known Veena Kalra, Dr. Veena Kalra, and I think there are 3 things that really distinguish her from other people that I know. One is her very calm and level-headed nature. And the second is her extreme generosity. And with that, I welcome you, Dr. Veena Kalra. It's a pleasure to have you here today.
Thank you very much, Rashmi, for that very, very kind introduction, more than I deserve. Thank you very much. And thank you very much, President of the Rotary, Ritesh, and everyone else who's been held important positions in the Rotary at some time and are doing wonderful jobs wherever they are placed now. It's been a pleasure listening to all of you for the last couple of minutes. It's been so nice to listen how much people are contributing in so many domains. In children, how to teach them good behavior. It was amazing. I noted down the points from that possible session. It's a pleasure. I think the reason why we are meeting today is in the midst of a dismal pandemic that's caught the world by surprise. The most developed to the most underdeveloped, everybody's been leveled by this pandemic. I think that's the tragedy of the pandemic. So I think what we are going to do in the next 25-30 minutes is to talk about this. And more than that, I'd like to have interaction from the participants to listen about their experiences, their good and bad practices, and also clarify any doubts if I can down the line. So I think with this, I'll begin with my formal presentation. COVID-19 began in the year 2019 in Wuhan, in China. From 2019 to January 2020 to March 2020, it really engulfed a huge part of the world. I think it traveled far and wide in devastating proportions. As of 10th of May, we have about 157 million people across the globe that have been affected with this devastating disease, and over 3 million deaths. So you can imagine a proportion of this pandemic. The other important thing is that I was just checking whether obsolete places like Greenland, Iceland, not commonly visited, are they spared? But I could see that even they have experienced the wrath of this, this virus. So I think with this, I'll then begin to talk about our experience about this pandemic. Now, my first objection is that the virus has produced such a deadly state, and we bring it out in media in various beautiful colors, blue, green, red. I really strongly object to beautification of the virus for visuals. I really don't like it. I think we have no business to give it such bright colors. We should not look at it that way anyway. So the last century has seen 6 pandemics. The first was the Spanish flu, which was in 1916, which was huge, which was even, the proportions were more than even this. And a huge proportion of humanity died. There were lack of resources, there was lack of information, there was lack of preventive measures. And then after that, we've had the Hong Kong epidemic, and then we've had the Middle East epidemic. These are the respiratory epidemics which have all come from this so-called RNA virus. From the corona, I put RNA because the corona is an RNA virus. RNA is a form of genetic material which doesn't have 2 strands, which has 1 strand. So it's really an incomplete genetic material which has lots of spike proteins, the red ones that we see on this ball, which are the ones that produce the problem. So other than this, we've had epidemics that have come from HIV, Ebola, and Marburg disease. So the last century has seen 6, but this one doesn't seem to end. It's more than a year and a half almost, and it's still raging all over the world. The WHO called this a global pandemic in March 2020. Origin was much earlier in 2019. So this is predominantly a respiratory virus. The predominant site of pathology is the respiratory tract. It enters through the nasopharynx, through the throat. It sort of attaches itself to the membranes through the spike protein and affects the cells through the ACE mechanism, which is the acetylcholinesterase mechanism of the human body, which produces a lot of pathology in terms of an inflammatory response. The other unusual thing about this virus is that unlike many others, it's really shown unusually more common, more frequent, more devastating mutations, which really bring this virus into a lot of thought as to what it's all about. The transmission is from person to person. It's from droplets, as we first thought. Droplets means something that you speak or you sneeze or you cough and droplets get into the ear and they settle on surfaces. These are droplets. So there was a lot of stress on cleaning surfaces, cleaning hands, using your arm to protect when you are coughing and sneezing. But down the line, we realized that it was more than droplets. It's airborne. So which means the particle size is smaller and it can remain in the air for anything like 3 to 16 hours after an infected person has visited the room. So you may not see the person, you don't see the virus, but you can still get infected from the environment. And that's the caution we all have to use. And that's the caution we all have to convey to our people. The incubation period is anywhere from 4 to 10 days, usually 4. And the infective period is about 10 to 14 days plus. That's of active period when you are infectious for others. The disease could persist for a lot longer. Now, how do we suspect this illness? The illness is very, very nondescript. It could be very mild. It could be like any common flu, any common virus. You get fever, which is not outstanding. A very low-grade fever, 100 degree Fahrenheit, 100.5, not a very remarkable fever in about 60% of patients. And there are a good 30-40% who don't even have fever. So therefore, they would never know that they are carrying the infection and the virus, and they would have spread it to so many people. The other common symptom is that we get cold-like symptoms in about 50%. Loss of taste and smell, though in a small proportion, but is a very characteristic symptom which helps you to identify this infection. Lung infection in the form of pneumonia of variable degree could be present. Headache, body ache, extreme fatigue is a very important telltale evidence in about 35% of patients. About 1/5 of them get what we call GI symptoms in terms of nausea, vomiting, diarrhea. So these are the mild symptoms on the right side, left side. The arrow points to the more sinister symptoms, which is what produces problem with this disease. In about 12 to 20, and in high-risk patients, it could be even up to 30%. What you get is a severe respiratory failure, acute respiratory distress syndrome. You get cardiac involvement due to the heart muscle, or even due to thrombosis in the vessels. Then a very important part is inflammatory reaction, which I mentioned. The spike proteins enters through the ACE pathway and incites a huge cytokine reaction in our body. So there are inflammatory markers that are pushed out in the system, like the ferritin, the D-dimers, the interferon, you name it, and this virus can produce any one of them. And in anybody who has a severe disease, this becomes the bugbear after about 5 to 6 or 7 days of the illness. Neurological symptoms like you could get a stroke, you could get loss of consciousness, you could get extreme muscle weakness, so you can get any neurological symptom with this. The one that's been recognized more recently, but in a very important way, are thromboembolic phenomena which develop with this virus because it interferes with the platelet pathways and therefore sets up thromboembolism in multiple tissues, giving rise to multiple system disorders. In children, very recently, there are reports of something that we call a multi-inflammatory syndrome of children, and in neonates. This is called the MICC when it's in children, and MICN when it's neonates. So it hasn't really spared the neonates or the children, and the manifestation could be even more bizarre. Now, so the sum and substance is that we are in an epidemic setting, and therefore we have to suspect this infection in anybody who presents with an illness, or sometimes who does not even appear to be sick, but has just had a contact with a patient. So how do we go about testing these people to see whether they are harboring the virus? The most important thing is to do a nasal and an oropharyngeal swab, and we look for the virus. This is called the reverse transcriptase PCR, polymerase chain reaction. This is the standard test that's done. It doesn't have 100% positivity. It has a positivity rate of anywhere between 60 to 75%. So therefore, even if you have an infection, you could miss it in one. And if you strongly suspect, you may need to do a second test again in the same patient. Then there is a second test, which is very quick in its answers, rapid antigen test. You can get an answer within about an hour's time, and therefore it has its advantage. The sensitivity is lower than the RT-PCR, which is the standard test. Then last is what we call the nucleic acid amplification test. So these are broadly the three tests that are used to identify the virus in the nasal and oropharyngeal secretions. So in all suspects, early testing is the key. You may land up testing a lot more people and find negatives, but then it's important because that one person could be a spreader or even be a super spreader for the community. Therefore, early testing and recurrent testing, if suspected, is important. Asymptomatic contacts of patients who've had a COVID infection in their family is extremely important. Then is all international travelers, national travelers, people who have attended societal gatherings, religious gatherings, different types of gatherings in different societies, different people, are all at high risk and must be tested. Community testing is important when you begin to get upsurges. And this community testing is what India did. And when we determined that the pickup rate rose up from a 5% on random testing to about 15–18%, we knew what was coming. So therefore, community testing alerts are extremely important to detect what may be coming shortly in the near future as far as COVID is concerned. Now, after we've realized that it's really an infection that really defies very easy diagnosis or easy measures of prevention, yet we must know that the core, the trinity of prevention is very simple, can be followed by everyone in whatever setting, whether they are in the home, whether they are in the family, in the community, district, office level, everywhere. So this trinity is of masking, which means, if you remember, I talked about the droplet infection and the aerosol infection. Masking reduces the presence of droplets and aerosols from a suspected patient. Now, this mask should be ideally an N95, or it could be a surgical mask along with a double mask that can be used. But what's important is that there shouldn't be air leaks from the side of the mask or from the nose bridge. So if you breathe and you get a spray on your glasses, you know your mask isn't fitting you snugly. So this is as far as masking is concerned. Masking is advised for everyone. And if you are tending to a family member at home, then masking is crucial all the time. It's not that you put on your mask, you pull it down when the person has walked out. Remember, as I just said, that the aerosol remains in the room after you've left the room for a couple of hours. So masking is of extreme importance. Next is social distancing. Social distancing, we know, is about 2 meters or 6 feet. That's the recommendation, because we know that droplets carry that distance as far as we are concerned. So that helps to reduce the droplet infection. Washing of hands, well, with soap and water for about 20 seconds, washing it frequently before looking after a patient, coming back from office, before eating, after looking at somebody who's had a possible infection, for doctors, for all healthcare personnel. This is the gold standard of keeping yourself safe and keeping others safe. So we must wash, we must sanitize rigorously. Then is we must prevent appropriate undue congregations, social, religious work together, because person-to-person transmission has to be prevented at all costs. The government has a role in putting appropriate lockdowns when they find that the infection is going beyond limit and wherever we find hotspots of the disease. What is most important in this disease is the connect upstream and downstream of communicating. The government will have to communicate with international channels, communicate downstream to the district, to the community, to the family, and to individuals. And this is a very important channel of information that must stay alive. We must be abreast with what's happening at the international front. What do we approach international agencies for our country? How do we pass that information benefit on to our district, community, families? So I think there has to be an upstream and downstream communication pathway that should be open, active, alert for us to reduce this infection. Then coming that we must acknowledge efforts of health and allied professionals and all people working in offices who are working day and night to keep everybody else safe. I think we must look after their safety, we must look after their nutrition, we must look after their work hours, fatigue we must be avoided, we must provide them safety kits, we must provide training to the community workers to be able to look after people and yet keep themselves safe. The action here is also to have materials that are necessary, which include safety gears, safety for the eyes, safety as a face shield, safety as gloves, safety as PPE kits, depending on what kind of job you are doing for the patients. Safe spaces should be created. And what is a safe space? A safe space is one which has good ventilation. A safe space is not necessarily one which is air conditioned. A safe space is one that has good exhaust and good ventilation. Then the other thing is to have adequacy of thermometer need for recording their temperatures. Then we need their heart rate, their pulse rate, and also sort of feel comforted that they are fine and they know when to solicit help from within the home or from even more health professionals. Then the important thing is to get drugs that are needed for COVID. Unfortunately, COVID is a viral infection. We don't have any drug that we can call is a COVID drug. What we are using as drugs are drugs that are made to comfort the patient, like a paracetamol and other drugs that I shall be talking about down the line. Monitors are necessary in hospitals. So I think these are materials that we have to provide. Isolation with hospitalization preparation is important. And remember that this pyramid tells us that the large majority of patients are at the base of the pyramid. They don't need hospitalization. They don't need major drugs. They just need care of their symptoms, and they need giving them strength and consolation that they will overcome their illness. That's the largest majority. That's the base of the pyramid. Then is a small section in which hypoxia or oxygen becomes the whole limiting factor. Many of them can be managed from homes if we can sort of monitor their oxygen, give them oxygen concentrators, or give them methods of respiration like lying prone on their belly, which increases the oxygenation. When you lie prone on your belly, your heart doesn't fall on your lungs. Heart is a huge organ. If it doesn't fall on the lungs, your lungs can breathe more. And that is how lying prone is a very, very useful parameter to improve oxygenation at home. Then these patients should be advised to do walking within the home frequently, because walking slowly for 5-6 minutes improves oxygenation. And if by walking frequently their oxygen is dropping, that's a sinister sign. So that is another very simple home test that can be used. The tip of the pyramid is the one that's colored red. This is where we need intensive care setup. These patients have severe disease, which could be one system or multi-system disease. And this requires high-level medical care, high-level monitoring, high-level involvement in looking at testing, everything. This is a high-level area. So this is as far as an individual patient is concerned, but what at the government level, what we need to do is look at containment facilities in zones that have high COVID density patients. They must be contained within their society so that they don't become super spreaders for everyone. And then are the quarantine facilities for people who've traveled, people who tested positive. So this is necessary more from the travel point of view. Then now I'll dwell a little bit upon what happens to a patient who's in a home. It's important that there's self-care. It's equally important that there's safety of contacts. The most important thing is to ensure confidence in the patient. They must never lose confidence. 90% are going to get well with simple drugs like paracetamol, breathing, fluids, hydration, looking after their symptoms. They are going to get well. They are good. They should be advised breathing exercises. It helps them to oxygenate themselves better. On the left-hand side are the monitoring parameters. Temperature should be monitored 6 hourly. Respiratory rate should be monitored. Respiratory rate over about 24 is something that we should get concerned about in an adult. And SpO2, this is the partial pressure of oxygen, which is normally about 98, 97, 96. This is the range usually. So this has to be monitored by the pulse oximeters. The symptoms should be taken care of. Any new symptoms like a diarrhea coming up, cough coming up, that has to be treated symptomatically like any other infection. If the SpO2, that's the partial oxygenation pressure, begins to drop consistently below 94 and walking does not improve it, you know that you fall in the gray zone and you must be in touch with a doctor. Then we come to the right side of this triangle. Here, if you have breathlessness, you have a respiratory rate that goes above 28, 30, you have multi-system symptoms, you have a diarrhea, you have a bad cough, you are out of breath, you are extremely fatigued, you can't get up, you are unable to eat, you are not as mentally alert. These are the multi-system signs. You have leg pains. So if you have these signs, you need to get into some kind of care. Okay. Then, okay. So if you have an SpO2 below 90, we need to solicit medical help early. For the patients, what do they do on their own at home? They must hydrate. Drinking a lot of fluid is a very, very important. You must drink 1.5 times the fluid that you normally take, because you have fever, because you are breathing a little fast, you are losing breath, and sometimes you have diarrhea. So therefore hydration is important. Isolate. Then there are these little things like zinc, which we believe is an immunostimulator or immunomodulator, giving about 50 milligrams of zinc and 500 milligrams of vitamin C on a daily basis, which helps. Medications are really in terms of symptoms, as we know. Here I would say that traditional wisdom is important. There are many immune things that are used. In India, we use milk and turmeric. They have no proof yet, but I think we should follow the traditional wisdom. Okay, so this is as far as home care is concerned, and I've mentioned when do we need to do solicit medical therapy. This is a very busy slide which talks about the protocol aims followed for mild, moderate, and severe disease. So I've already talked about the mild ones at home, and I've dealt with how to suspect a severe. As I mentioned, a respiratory rate of more than 24 and an SpO2 of less than 94. So this is the category that we need to think about. The severe ones, we definitely would need hospitalization because they need significant interventions. Not missing a COVID pneumonia or a bacterial pneumonia. We're not missing shock. We are using drugs like antiviral drugs like remdesivir, etc. in needy cases. And then there are many other drugs that we can opt this into the next slide for easy understanding. These medicines that are being used are the ones that are called repurposed drugs. What is a repurposed drug? A repurposed drug is a drug that was discovered for some other reason, but we think it may help COVID. Ivermectin, initially an anti-vermicidal drug, in vitro experiments showed some benefit to COVID. So it was tried. But in true life situation, we don't reach the doses enough to produce. Therefore, there were immense use in the last year, but now the latest WHO recommendation is that ivermectin probably has no role. Same also for hydroxyquinolones, same also for doxycycline. Therefore, these are all into question marks because these have not proven any significant benefit. Then is remdesivir. Remdesivir is also a repurposed drug. It was initially discovered for hepatitis C. And subsequently, it's been used for other viral infections. And same in this COVID infection, it showed that when you give COVID to moderate to severe patients, it helps to reduce the number of days of hospitalization and probably a quicker recovery from a respiratory illness. So this is where remdesivir stands today, a drug that is much sought of once you get moderate to severe disease. Then is plasma therapy. What is plasma therapy? Plasma therapy is that you have a convalescent patient, which means who's recovered from COVID. So he's got huge dose of antibody to neutralize the viral load, and therefore may help. There are not enough scientifically conducted trials to say whether it's of great use or not. But then steroids are used in moderate and severe COVID as injectable steroids or oral steroids in large doses. The doses that we use are methylprednisolone, dexamethasone, and these have definitely shown benefit in reducing the COVID-induced pneumonia. And this has been seen that when you do a high-resolution CT scan of the chest, you get a COVID pneumonia, steroids. So this is where your steroids come in. They are a bridge between mild, moderate, and severe disease and help. Then there are newer therapies. The world is really trying hard for newer therapies. There are new monoclonal antibodies that have developed, tried in decimavir, Ubab, then casirivimab. So these are all monoclonal antibodies that we find. Monoclonal antibody means that it's an antibody that goes and specially clones to the spike protein, to one of the limbs of the spike protein, and reduces its entry into the cell to produce disease. These are monoclonal antibodies. Then are a large number of new antiviral drugs, primary antiviral drugs, which are beyond the scope of this talk. But I would say that they are being tried immensely, and some of them have even put into clinical trials. Then are the interleukin inhibitors. If you remember, I mentioned that there is a cytokine storm in some patients, and interleukin inhibitors help in that. The last drug, 2-deoxyglucose, it is something that has come about from the Indian research labs just about a week ago. It is a deoxyglucose, which it's in a packet, you dissolve and you take, and this deoxyglucose permits the virus utilizing the glucose of the body. So in a way, you are starving the virus of its nutrition. This is something that has come up very recently, and the drug is going to be marketed coming week. And let's see what it does in terms of clinical sequence. Of course, the most important part of any viral infection is prevention, especially when the proportions are so high. Vaccines, more than 100 are under development, but the ones that have already reached the market are enumerated. Remember that vaccine production for COVID has been the fastest in history that one has ever seen, and the most numerous in history for any disease. The adenovirus takes the COVID virus and you produce an antibody. This is the Johnson & Johnson virus. And then there are the chimeric adenoviruses, which is the AstraZeneca, which is produced, came out from UK, and the Serum Institute of India is producing this by the name of Covishield. Then are the vaccines which are using dead viral particles along with aluminium hydroxide, which helps to neutralize the pathogenicity. This is Covaxin. Then is Novavax, which is a recombinant nanoparticle. And then there is another adenovirus, which is called the CanSino, the Sinopharm, and the Sinovac. These are all the aluminium hydroxide related. Remember, aluminium hydroxide used to be the adjuvant for virus vaccines in the past. So one has resorted to the same old pathways of developing vaccines. GAM-COVID, which is called the Sputnik, is the one that has come from Russia, and it deals with 2 incompetent adenovirus vectors, which means they are capable of producing antibodies, but not disease. That's why they are called the incompetent. So I think with all these, I would say that use what you get. Don't worry. Don't worry. They have a different degree of efficacy. We don't know about their long-term consequences. We know about some short-term consequences, and what we know today will be obsolete 3 months from now. So therefore, use whatever vaccine you get to protect yourself. Remember, some vaccine is better than no vaccine. So now I'll touch upon the virus variants, which I said was the great bugbear of the COVID infection as against the other viruses. The virus variants are the ones in which the virus mutates. And when it mutates, it changes its protein. And when it changes its proteins, its characteristics change. It may become more infectious. It may become more resistant to drugs. It may become more resistant to vaccines. So therefore, these are the various things that happen. In UK, we detected the B117 UK. In India, we had the double variant B.617, and now in the last week, we've determined 3 more was 6.7, 0.1, 0.2, and 0.3. So therefore, there's a quick mutation that's happening. In Brazil, there was the P1 mutation. In South Africa, 1.351. Numbers don't matter, but what's important to remember is that it's mutated in a whole lot of countries. And there are many other reports. I've just picked up some of them. As I mentioned, that they may be more infectious, they may be more deadly. Which vaccine will work on them, we don't know yet. But what's good is that there's a global initiative that's tracking all the mutations in all the countries and sharing with each other to develop some harmony about the knowledge that we have. Then coming to the vaccines, there's an international alliance called the Global Vaccine Alliance, which is called COVAX. Now, why was this necessary? Because globally, we confirmed 157 million cases. Globally, we confirmed 3 million deaths. Global vaccine coverage has been very variable in different countries, understandably so, that countries where it was produced obviously used it first for their own countries. And obviously there were areas of the world where the first brunt was born, where the vaccine began to be used. We were all unprepared for the catastrophe, and therefore are producing the amount of vaccine that is required will really take some time. But I would say the scientific community has left no stone unturned in its effort to gear up production, to gear up research, and to gear up trials. I think that's the important thing. And the dictum is that unless you vaccinate everyone, no one is safe until all are safe, because the world is boundaryless today. The world has no boundaries today. Therefore, we have to think about vaccinating the world. But remember, weaker the health infrastructure, the greater is the challenge. And that's what we have to keep in mind. Therefore, a weak health infrastructure must protect itself by using the trinity of protection: masking, safe distancing, avoiding big groups, sanitizing, and keeping patients away from the general community. Therefore, I think this is the important message when you don't have the other infrastructure on place. So this is a slide that I saw today from Johns Hopkins. This is about an updated list on the 10th of May, which talks about confirmed cases and confirmed deaths in different countries of the world. Deaths, case fatality rate. I think I'll come to this third row. Vertical row. So the case fatality to 3%. This is the global that. And if you see, India is in 1.1%. And I think we have done well to keep our population safe against deaths in a large proportion of the population. So I would end up my talk saying that I wish to thank you for inviting me. I wish to thank you for my sharing this with you. And I would say, despite uprooted health, uprooted lives, uprooted nations, uprooted economies, have faith. This too shall pass. So with this, I end my talk. And now I would like to entertain questions and experiences of others. Thank you.
Thank you very much indeed.
So back to the chairperson.
Thank you. Thank you very much indeed, Professor Dr. Kalra, for this wonderful presentation. And it has truly enlightened us, and it was very thought-provoking. At the same time, we do understand one very important point you have put across, that some vaccination is better than none, especially at this point in time. So with that, I would like, if it's all right with you, if you could kindly stay on for a few more minutes. And first, I would like to call upon our past president, Dr. David Gitanga, who is also the chairman of Kenya Pediatrics Association and the Nairobi Hospital, to kindly give a vote of thanks to you on our behalf. And thereafter, there are some questions which have come into the inbox, and we can raise those. Is that all right with you?
Yeah.
Perfect. Can I please request our past president, Dr. David Gitanga?
It's fine. I think I've overshot my time. I'm sorry for having to overshot my time.
To be honest, the meetings are quite fluid. We are grateful for your time. We are honored with your presence, and we can spend as much time as you are willing to share with us. So thank you.
Thank you. Yeah, thank you.
Dr. Gitanga?
Thank you very much, Past President. I stopped being the chair of Kenya Pediatric Association 5 years ago, but I'm still associated with the association. But it's always a great honor when you are asked to respond to basically your teacher. When Professor, you'll allow me to call you Professor Veena, was graduating with her bachelor's degree, I was in standard 4. That I should be asked to respond to her now, it's quite an honor. But I must say she is a quintessential representation of a teacher. She really did take us very well through the whole system, pathophysiology and treatment management of COVID-19 disease. And if it was possible, I think all of you that were awake should really be awarded some sort of certification, because she really taught very well. Manu, you'll become a doctor ×2, having gone through this lecture. I think she said some very, very, very important things. And initially, remember, there was a lot of confusion about surfaces and so on, and the whole debate about whether these are suspended particles or not. But she's made it very, very, very clear that suspended particles that remain for a long period of time in a room that's poorly ventilated, then you get susceptible. And I think that is important for a group like ours, where we worry about cross-infections. Of course, she brought in an awful lot of conversation and information about the vaccines, where they exist, and many things that are important to have a few take-home messages. And one of those is to know when you're not doing well. I think one of our past presidents did offer pulse oximeters, and she did indicate that you must know when you're not doing well so that you decide to seek treatment early, and that is important. So a pulse oximeter is one of those things that's important. The other one is really social distancing, as well as taking fluids and so forth, and that is really on a home front. So for me, is to really thank you, Prof, for really taking us through a very, very complex and fluid subject, taking it very well, and really giving us a message of reassurance that despite all this, we will emerge again. Thank you very much, Professor Veena.
Thank you very much, Dr. Gitanga, for your kind comments, and for inviting me, to Dr. Ritesh and to all other members who invited me for this talk. Thank you very much. It was a pleasure being with all of you.
Thank you. Thank you so much, Professor Dr. Kalra.
Are there any questions? Are there any questions?
Yeah. Yes, there are. And
yes, I can see that there are some questions. Yeah.
Yes.
I can see there are some questions.
I would like to call upon Professor Michael Hopkins. Professor Michael Hopkins, if you can kindly ask your question.
Thank you very much, President Ritesh. I assume you can hear me okay. I'm having sound problems here.
Yes.
Thank you, Dr. Veena, for a very clear talk, but unfortunately only managing to scratch the surface of such a complex issue. One question I have, and I see others have got a similar question, is that many of us in Kenya, and probably many of the people watching today, have had a first vaccination, the AstraZeneca vaccination, but our second has been postponed even after 2 months because of lack of the vaccine here in Kenya. If we go to another country, could we safely take the AstraZeneca vaccine dose that is offered there? Or what other alternatives would you suggest? Or would you say that the coverage of maybe 65% of the vaccine in terms of protection is acceptable, and that we shouldn't worry too much about the second dose. I might be a doctor, but not your clever sort of doctor, I'm so sorry to say, just an economist.
Can you hear me?
You're breaking up for me. I don't know.
Am I with everyone?
Yes, yes, we can hear you.
Hello.
Yes.
Hello, can you hear me? I think you raised a very important question, Michael, see, ideally we know that a single vaccine will not prevent totally. But then even 2 vaccinations are not 100%. So therefore, if you've got one, you have to wait for when it becomes available to you. But it's still important. Now the question is, do you give 1 to everyone, or do you give two to a select few as a country? That's a big dilemma. That part is a big dilemma. But I think if we have susceptible, vulnerable age group, we have health workers, we have professionals who are on the forefront, they must get the 2 doses and not just be content with 1. Can you hear me?
Yes, I heard you, and and your answer. I do have other questions, but I think other people are on the line too.
Do you agree with what I say? Do you agree with what I say?
No, I absolutely. In terms of priority, of course, it's and very, very difficult to know, and very difficult for a government to decide on priorities.
Sure. Sure.
And if I'm worried about the economy more than anything, actually, as indeed you are in India, I know.
Certainly.
And here in Kenya, especially small businesses and so on, have been hit pretty badly, and people end up without any income whatsoever. Therefore, criminality is increasing. Possibly illness and death is increasing because of poverty, not so much because of COVID. But that's, of course, is a huge and different issue that myself and others, including my friend and colleague Mike Eldon, have actually suggested that every poor person gets a basic income actually to prevent this. And that could be easily affordable, believe it or not. Same in India, by the way. But that's entering another big discussion, and I leave it for other people.
That's true.
Thank you very much.
Our Prime Minister did a lot in this line during the COVID. Food was given to the underprivileged. Money was put in their bank accounts. I think a huge amount of effort from our Prime Minister has gone into all this.
Yes, they have. I would also not advocate giving people food. Much better to give them money, because they can then choose what to do with the money. When you give people food, they might not need it. And anyway, the day after, they're going to be hungry again. So money is much preferable. All right. Yes. Thank you very much, Dr. Veena.
Okay.
Thank you. And next, I will call upon Rotarian Winnie to propose her question, and thereafter past President Leah from Rotary Club of Bahari.
Thank you so much, President Ritesh. Thank you, Professor Dr. Kalra, for that. What is the current situation in India? Really, it is quite alarming, and the COVID cases have really raised. And what is the government doing?
That's
really?
Right.
This is such a sad situation. What is the government doing to ease this
See,
situation?
the last month, there's a sudden spike of cases all over the country in different states differently, but there was tremendous increase in the major metropolitan towns and in many states. So I think what has been done is, first of all, a lot of vaccine has gone in. Also, healthcare setup was produced, beds were produced on emergency basis, oxygen-related beds, intensive care beds. But I think we were still behind the graph, and we did have an immense upsurge in the last 1 month. But if you see in the last 5 days, Mumbai, Maharashtra has come down significantly. Delhi has come down significantly to almost 40% of what it was about a month ago. But I think at the end of the earlier phase, we were caught a little unaware, and there was a sudden spike. I think there was also some relenting in terms of congregations, social distancing. There was a little letdown by people. I think there was an element of not being so rigorous as the disease wanted us to be.
Okay. Thank you. Thank you.
But we've done a lot of emergency beds, a lot of emergency things. Yeah.
Thank you very much.
Thank you. And now I'll call upon past President Leah. Are you with us?
I am. Can you hear me?
Yes, we can.
Okay, thank you, Dr. Kalra, Professor. So my question is multifold. If we can't get the second AstraZeneca shots, those of us over 58 and frontline workers have been fortunate enough to have the first shot. And we've been told, first we were told maybe June, now there's talks about maybe not even that because of what's going on in India. And that, so are we, if we are asked to cross-vaccinate, is that something, how can we make decisions on that if Kenya does get the Pfizer or Johnson & Johnson as they're applying for from AU? This, and also about we have a lot of conspiracy theories. A lot of Kenyans I know, highly educated, including Rotarians, just don't want to even deal with vaccinations at all. They don't think it's necessary. They think zinc and ivermectin will be fine for them. So what do you think the Kenyan government could do as an aggressive disinformation campaign? Because so far nothing seems to be getting into their head. And also, I know I read I think Washington Post report today. In America, they're thinking about pediatric vaccinating now the children, and some Indian pediatricians wrote and said, hey,
yeah.
You don't have to do the children when there's so many people around the world who don't have access. So vaccination disparity, what can be done about that? Thank you.
I think the most important thing is, first of all, your question was, can we use an alternate vaccine as a second dose? That was your first question. I think it can be done. It can be done. We should broadly use the same family of vaccines, but it can be done. There are 3 of them that are the RNA vaccines. There are others that have used aluminum hydroxide. And there is the 3rd one that uses the adenovirus. There are these 3 broad categories. So one can use the alternate. That's not, that's on. Coming to motivating people for vaccination, I think one has to have information campaigns, especially for the at-risk people, at risk due to age, at risk due to other comorbidities, at risk for their work situation. They have to be the first line to get it. And I think they will have to be motivated because there is no other outcome. Ivermectin, zinc are not really, they don't really reduce the infection rate. They don't reduce the infection rate. So while as I mentioned in my talk, that today there was a message from WHO, there's in writing that ivermectin has no role, which we've used almost for 1 year. We've used almost for 1 year.
Thank you very much.
Thank you. And next, I will call upon past President Elizabeth.
Good afternoon, President Ritesh. Good afternoon, everybody. Thank you for a nice meeting. Sorry, I've got my video is on now. Can you see me?
Yeah.
Sorry,
Yes,
can you see me now?
We can.
Okay. There's just something that I've picked up, and there was a whole article, I think a month ago, that you cannot mix vaccine. And I've just had the Dr. Veena say that you can actually mix. So, and that came from WHO, it came from the local medics here. So I stand to be corrected, but I just need to be clear on that. You're the first one I'm hearing saying that you can mix vaccines, and it's a bit of concern, please. Thank you.
What I said is that the same group of vaccine can be given. The mRNA vaccine can be used. Similarly, the aluminum hydroxide vaccine can be used as a second dose. You don't interchange the broad categories of the vaccine.
Okay.
They work by
All right.
different mechanisms. They have been produced differently. So you can use another company making the same type of vaccine.
Oh, the same type. Yes. So you can't mix the Pfizer and
Yes,
AstraZeneca
yes.
or Johnson. Correct. Okay. That's what I needed clear.
You can't.
Thank you very much.
Yes, you
Thank
can't mix. You can't mix. Yeah.
Thank you. Thank you.
Thank you very much for the questions. And Professor Dr. Kalra, would you like to take on one or two more questions, or should we call the meeting to an end?
Sure, no problem.
One or two more questions. Perfect. There's a guest, a gentleman by the name Santosh, who had a question, and thereafter your dear friend Miss Monica Gokaldas has a question.
Okay.
I think Santosh left.
Ah, I see. Well,
I saw that. Yeah.
Right. In that case, I think we should go ahead to the next question. Miss Monica.
Monica.
Yeah, thank you, Ritesh. My question was same as already been answered for the cross vaccination.
Okay.
That if I have got AstraZeneca and it's not available, can I take another one?
Of the same category.
Of the same that you answered already. Yeah,
category.
that's good.
Yeah.
And another question, if someone has traveled and come, like for instance, my daughter is in quarantine at the moment, having returned from Kuwait. And she went for her test today and it's tested negative. So is it safe? It's been 5 days now since she came into the country, or should she still be in quarantine?
Quarantine procedures are very different in different countries. For instance, Hong Kong quarantines you for 21 days, even if you are negative. See, first of all, you can't travel if you are positive. So it is presumed that everybody who's traveling has a negative certification. That is presumed.
Yeah, that's mandatory.
You may turn positive 2 days later. So the quarantine has been variable. They have, in fact, over there, they ask you to undergo a hotel quarantine. There are other countries that go through a home quarantine after 5 days, in which you continue to inform the authorities of any symptoms, but you are at home. So I think this is the thing.
Yeah, so she's also been at home, but she's been in
but
quarantine.
The quarantine should be maintained for at least 10 days.
10 days.
Yes, even then, because you may turn positive after 5-6 days. That is possible, and the test is only about 70 to 80%. It's not 100%. An initial negative test may turn out positive on a second testing.
Okay, understood.
Yeah.
Thank you.
Thank you very much indeed. And for the last set of questions in this order, first is Dr. Beatrice Kiptanui, followed by past President Juvenal Shiundu, and finally Ambassador Dr. Josephine Ojiambo.
Well, thank you very much for the presentation. We value all the information that you provided. Coming from a medical background, mine is really a question on how you feel we as healthcare providers have worked with the new information. It's an unprecedented time of new discoveries and new situations for us all. And I feel we have a duty to minimize the confusion to the general public and even amongst ourselves. How do you feel we have performed as healthcare providers and researchers in combating the inherent competitive nature of medical practitioners and even pharmaceutical industries vis-a-vis coming together to fight a common enemy for the greater good of the masses?
Believe me, I think the healthcare workers have been at the forefront of this fight. They have risked themselves to help others, and I think they need to be complimented in as many words as you say are less for them. Do at your own risk all the time. But then they are trained for that. There's something in them, there's a fire in them to do all this, and I would compliment them. I think what one should do is one should create some standard operating procedures in every hospital or every setup for their own safety. I think creation of an SOP, whereas their safety should be looked into, their working hours, their diets, all this should be looked into. But they have done extremely well. I would say even for the pharmaceutical industry, they've really slogged to produce the amount of even paracetamol that you needed in a country. You never needed so much paracetamol in a country. It's a simple drug. You never needed so much zinc in a country. You never needed vitamin C in a country. Just see the amount of common drugs that needed to be scaled up to such proportions to reach every person. In our country, our Prime Minister, of course, did very good thing. He produced lots of events in which he asked people to clap for the workers, to make bells for the workers. It was just a gesture. It was just unifying ourselves, the general public, with the healthcare workers. I thought that was very nice.
Thank you so much. And next we have Past President Juvenal.
Yeah, thank you very much, Dr. Kalra, for a very interesting talk. Mine is when you ask different doctors about whether you can take different types of vaccines, you get different answers. Yesterday, I put this question to a doctor in London. The reason being that on 3rd of March, I took a vaccine in London, AstraZeneca, and I was meant to take the second one on the 25th of May. So I was to travel back to London end of May and take the second one. But now with the Kenya being put on the red list, it means that I may not be able to travel to London. So I put this question yesterday to a doctor in London, whether it is possible to take 2 different types of vaccine. And he did mention that although there has been no tests, but they believe that taking 2 different ones, for example, taking AstraZeneca and then taking Pfizer, that may actually be better than taking 2 of the same. So it seems that, and then I put this same question to a different doctor again in Germany, and I got the same answer, that it's possible to take 2 different ones. But from your answer today is the opposite. So who should we believe? Thank you.
The point is, these vaccines, they are not counterproductive to each other. Only thing is, they have a cycle in which they produce the antibodies. They have a cycle when they touch your T cells and B cells, which are the immune cells. So therefore, you believe that using the same one in a cycle is better. But I think nobody has tested that whether giving 2 of a different category will eventually be better. I think that we will know somewhere down the line. Nobody can answer that question as of now. But for your personal question, I think if you are not there for 4 weeks, this can be delayed up to 6 to 8 weeks without any problem. That's also possible. That 4 weeks is not just a borderline. You can go up to 6 weeks and 8 weeks. And it's recommended now that even going 6 weeks may be even better than 4 weeks as a second dose for your own vaccine, I would think.
Thank you.
Juvenal.
Thank you very much indeed. And now we shall take the final question from Vice President, Ambassador Dr. Josephine Ojiambo.
Right. Thank you very much, Professor Veena. That was a stellar lecture. Mine is a question from International Public Health, and it's about the response of the World Health Organization. I do note in your presentation, you brought it up and made it very clear that the pandemic was first reported out of Wuhan, China at the end of 2019. That's why it's called COVID-19. But that the World Health Organization itself pronounced the pandemic in March of the following year.
That's right. That's right. That's
3 months later. Now this
it's
is
actually more than 3 months. Yeah.
Yes, yes. This is our primary to go to global best practice standard setting organization. In 3 months, you can just imagine how far the virus spread.
I
What
agree
is
with you.
What is your discussion? What do you think about this? Yes, I leave it to
agree with you totally. I agree with, because see, these days, this is a world which moves so fast. International travel, one country, other country happens. All airports are full from one country to the other. So that is the potential for the virus to travel. So therefore, you may have been wrong. You should have sensitized early that this may happen if you were not sure. But surely information of this kind must come very early for people to begin to gear up their country for it. It takes time to gear up your country. It takes time to spread even simple messages. It takes time to reach out to the masses. It takes time to take public health measures. So therefore, I think it would have been much better if the world was at least warned that something of this sort may happen, even if you were not sure, I think.
Thank you. Thank you very much indeed. And Professor Kalra, we are very grateful for this exemplary discussion and the information you have shared with us. We are going to be uploading it onto YouTube for the many members who also want to view it again. We are also grateful to all the individuals who have joined us today and all the guests for this very informative talk. And also on behalf of Rotary Club of Nairobi and Radio 44 Kenya, we are very grateful for your time. And we are also very grateful for the engagement you had with the club members after the initial presentation. Thank you so much.
Thank you very much, Ritesh, and thank you for all the other members who invited me. I enjoyed being with all of you. And love to see Monica after a long time.